Good afternoon, everybody. Welcome to the first of what we hope to be many of the TeleSpecialists webinar series. Today we are very excited to present Dr. Mazen AbuAwad, who has been with NCH in Naples for about 5.5 years and was in St. Louis for 12 years before that. He is going to be presenting on acute ischemic stroke imaging and patient selection neurothrombectomy. If you have any questions, please hold them to the end of the presentation where we'll have some question and answer time. And we hope you enjoy his presentation. Dr. AbuAwad, I'm going to go ahead and transfer it over to you.
I'm going to be talking about acute ischemic stroke imaging and patient selection for neurothrombectomy. So mostly I will be talking about ischemic strokes. And so similar to the way that we think about MI, so we have patients with STEMI and non-STEMI MI. The same thing with stroke. We have patients with large vessel occlusion and patients with non-large vessel occlusion strokes. The patients with large vessel occlusions are the minority, and yet they they take up the majority of disability and mortality cases. Those are the patients that the recent trials showed that can benefit from a mechanical thrombectomy when it's done in a timely fashion. And also those are the patients whose treatment is highly dependent on time. The sooner we can get to those patients, the better the chance that we will have good outcomes on those patients. Now, when we talk about large vessel occlusion, I'm sure you all know that we are talking about patients with M1 segment occlusion and internal carotid artery occlusion. Those are the patients that were included in the trials. And also those are the patients that are included in the current AHA/ASA guidelines. We are treating patients who have M2 occlusions and also posterior circulation occlusions, but those are done outside the guidelines. Now, the majority of patients with large vessel occlusion have M1 segment occlusion. This is followed by internal carotid artery occlusion. Now, I'm sure you've all seen this caricature before, which shows when you have a proximal M1 occlusion, there will be a small core infarct that almost instantly happens at the site of the occlusion. And then the part of the brain that is distal to the core infarct will still perfuse indirectly through what we call collateral flow. And so that part of the brain will be oligemic, but it's still salvageable, and that part of the brain that we call the penumbra. So our goal is to prevent that small core infarct from growing and becoming the size of that penumbra and limit the size of the stroke. Now, we all know that the normal perfusion or the normal cerebral blood flow is above 60 milliliter per gram per minute. When the flow drops below that, the patient becomes oligemic, or the brain becomes oligemic, but the patient is still asymptomatic. The patient will start developing symptoms once the flow goes below 20 milliliter per gram per minute. And a core infarct will happen when the flow goes below 10. So between 10 and 20, that's when we have the penumbra. Now, the recent trials showed the clear benefit of mechanical thrombectomy over medical therapy alone in patients with large vessel occlusion, but that was also very highly dependent on time. So if we are able to open up the occluded vessels within the first 2 hours, the number needed to treat is 2 or 2.3. Now, as the time goes on, that number increases until we get to 7.3 hours, where the benefit of mechanical thrombectomy is not there anymore compared to medical therapy. So 7.3 hours, that's the key time. Now, this is when we look at all comers, all patients, okay, regardless of their background. But as we all know, that not all patients are the same. For example, here's this one patient who had a right or who has a right MCA occlusion, right M1 occlusion, he presented to the hospital within the first 2 hours from the time of onset of his symptoms. His diffusion-weighted image shows a small core infarct in the right basal ganglia region, measuring about 7 milliliters. Now here's another patient who had a left MCA occlusion, came to the hospital within the same time frame, within 2 hours from the time of onset of their symptoms, and his MRI shows a stroke involving almost the entire left MCA territory. So this is a diagram from the Dawn trial that showed that the stroke volume is actually, there's a relationship between time and stroke volume, and that relationship is not linear, it's more of an algorithmic, where we have a rapid rise in the stroke volume initially, and then that volume will plateau at a certain point. Now, in some patients, the progression of stroke volume will happen much faster, so that line will be much steeper, and those are the patients that we call fast progressors. And then there will be another group of patients that the progression of stroke volume will be going at a much slower pace. So those are the patients that we call slow progressors. Now, this is a busy slide, but it is all these dots. This is from the University of Pittsburgh, where they had all their stroke patients, and they calculated the core volume, and they put that against time. So all these dots represent patients, and the closer to the baseline, the smaller the stroke volume is. And as you can see, there are a number of patients who presented early within the first few hours, 2 or 3, or maybe, definitely less than 6 hours, and yet had much larger stroke volume. Like, for example, this patient here who had almost a 250 cc of stroke volume, compared to a patient down here that presented almost 24 hours from the time of onset of her symptoms, and yet his stroke volume was almost 0. So why? And so, of course, the first group of patients we call the fast progressors, and about 25% of our patients fall into that category. And the other group of patients are called the slow progressors, and about 55% of those patients fall into that category. Now, we all learned about how when we have large vessel occlusion, the brain cells die at the rate of about 2 million cells per minute. Okay, now that's an average number. If you look at the diagram, you see that the range of cell death is really wide. So we have patients, so it goes from almost like 5 to 10,000 per minute to almost 25,000 or 25 million cells per minute. So we have patients, and those are the fast progressors, where the cell death or the neuron death happens at a rate of about 4 to 24 million neurons per minute. And then we have the slow progressors, where the neuron death happens at a rate of about 15,000 to 1.7 million. So why is that? That all depends on the collateral circulation. So there are patients who have much robust collateral circulation, so they have more blood flow going into that penumbra area, so it's able to survive for a longer time, and the ischemic or the core infarct will progress at a much slower rate compared to those who have poor collateral circulation, where the rate of death of those neurons will be much faster, and the core infarct will progress and increase in size at a much faster rate. So in summary, we can divide our patients with large vessel occlusion into those who are slow progressors, so about 55% of our patients, and those who are fast progressors. Now, this is going to be very important when we look at the different imaging modalities to evaluate those patients. So ideally, we would like to have something, when we image those patients, we would like to have something that is quick to perform, available 24/7, and yield images that are easy to interpret, and helps us identify patients who are likely to benefit from mechanical thrombectomy. We usually start by doing a non-contrast head CT. Non-contrast head CT is more of a densitometer. Basically, it measures the density of the tissue, and because when we have things that have different densities, they will look different. Like in the brain, the gray matter is mostly composed of neurons, and that's why it has a little bit lighter color, and the white matter will have the axons that have more fat and water, so that's why it's going to be darker, and that's why we see the gray-white matter differentiation. So once we lose that differentiation in density, that means there is a problem. There's more, like for example, water in the gray matter that's not supposed to be there because of the stroke. One of the most important slices when we look at non-contrast CT is the one that goes through the basal ganglia region. Okay, and I'm sure you've all heard about the zebra sign, which is supposed to be the normal appearance of the basal ganglia. It basically, it divides the basal ganglia region into 5 different columns. The first column is the one that goes through the head of the caudate nucleus and the thalamus. The second column is the one that goes through the internal capsule. The third column is the one that goes through the lentiform nucleus. And the fourth column is the one that goes through the external capsule. And finally, the fifth column is the one that goes through the insular ribbon. And here's a summary slide of that. Again, the slide that goes through the basal ganglia is the important one that allows us to look at the basal ganglia region. And that's important because the basal ganglia region is mostly supplied by the M1 segment or the perforators that come off the M1 segment of the middle cerebral artery. And those are usually terminal branches. So the collateral supply there is very poor. So when the M1 segment is occluded, those are the areas that affected almost instantly. And that's what we need to look at before we do anything. And we also can calculate the aspect score by looking at this slide. And we will talk about this later. Okay, so one of the things we look for is hypodensity. And that's when we lose the gray-white matter differentiation. So there's like vasogenic edema in the brain, and the whole thing just becomes uniform like the one we are looking at. This is more of an extreme case where you have a right MCA occlusion and the entire MCA territory is infarcted. One of the subtle signs that we look for is the insular ribbon sign. Again, the insular ribbon is supplied by the terminal branches of the MCA, so they don't have any way of getting collateral supply, collateral blood flow. So that's why that area will go out first. So that's one of the areas we need to look at when we evaluate non-contrast head CTs. Another one is the obscuration of the lentiform nucleus. Again, just looking at the basal ganglia region, make sure that we are able to see the differentiation and the zebra sign that we talked about. If we lose that, and then that means there's edema in that region, which is a sign of acute stroke. Another sign we look for is the hyperdense artery sign. Typically, we see it in the MCA. It's present in about 40 to 50% of patients with MCA occlusion. Now, just because it's not there, it doesn't mean that there's no clot in there. It basically represents a clot in the middle cerebral artery. And when the clot involves the sylvian segment of the MCA, it's going to look like a bright dot within the sylvian fissure. We can also see the hyperdense artery sign in the basilar artery and in the posterior cerebral arteries. Now, when we image patients with acute ischemic stroke, there are 4 critical questions that we need to ask now. Now, is there intracranial hemorrhage? Is there a large vessel occlusion? Number 3, is there part of the brain that's irreversibly injured, and that will be the core infarct? And is there part of the brain that's still salvageable or at risk, tissue at risk? And that part of the brain will be the penumbra tissue. Now, for the first question, to be able to detect hemorrhage, we can do a non-contrast CT. We can also do an MRI. Of course, CT is much easier, much quicker to do, and it's readily available. And usually blood will look bright on the CT, and sometimes will be surrounded by edema. And it's actually somewhat more sensitive compared to MRI, especially if we are looking for like subarachnoid hemorrhage. Now with MRI, there are some sequences that are susceptible for blood, and those are the T2 star images, the GRE, EPI, and the SWAN. Now we can also do CTA that will allow us to see if there was a large vessel occlusion or not. We can also do a multi-phase CTA, and that will allow us to evaluate the collateral circulation and see if there's a penumbra there or not without having to do a CT perfusion. On the images that you're looking at, so we have 3 rows. On the top row, we have a patient with left MCA occlusion, left M1 occlusion. But if you look at the next phase, the phase number 1, you can almost, the MCA branches are filling with contrast symmetrically on both sides. And as we go on into phase 2 and 3, you can see on the delayed images that there's still some contrast on the left side because the flow is still really slow, but those vessels are filling almost instantly. So this is a patient with good collateral flow. Now compare that to the next row where you have a patient with similar M1 occlusion, but on phase 1, you can see the MCA branches filling with contrast, but they're not as dense and full like the ones on the right side. And as we go on, they kind of go away. So this patient has okay collateral supply. It's not as good as the first patient. And the final patient on the bottom, so this is a patient with right M1 occlusion. And you can see on the phase 1, there's no vessels filling at all. And then on the delayed phase images, we see some of the vessels starting to fill in late. So this is a patient with poor collateral flow. This is a patient that will do poorly moving on. Now, another thing, another reason we do imaging is to try to estimate the size of the core or the volume of the core infarct. And we can use different modalities to do that. We can use a non-contrast head CT by utilizing what we call the aspect score. We can do a CT perfusion, MR perfusion, or even diffusion weighted images. And you can see on the images provided, the first column is the non-contrast head CT, and you can see on the left side, in the left MCA territory anteriorly, there is a subtle loss of the gray-white matter interface. And then on the next column, we can see the CT perfusion where there is abnormal perfusion in the same territory. And then on the diffusion weighted images, you can see the infarct in that area. And then in the bottom, you can see the non-contrast head CT with really no edema or any sign of effacement, but the perfusion shows a large area of abnormal perfusion, and the DWI shows a large infarct in the left MCA territory. Now, the aspect score is pretty much what we call a poor man's MRI. This is a scoring system that was developed in Canada. I guess because they don't have MRI readily available like we have it here, so the next thing that they could do was to get better at non-contrast head CT. So they developed this scoring system, which basically divides the MCA territory into 10 different points, and for every one of these areas, if it's abnormal, we deduct a point, and that's how we come up with the score. So a normal score would be a 10 out of 10, and as we deduct those points, we get a scoring system. So basically, we look at to decide the aspect score, we looked at the slice that shows us the basal ganglia region. Most of the points are there, and then we look at the slice above that level where we can get the rest of the points. And here's another patient with a large edema involving the left MCA territory. And as you can see from the 10 points, we have 3 that are still intact in the basal ganglia region, and those are the head of the caudate nucleus, internal capsule, and the lentiform nucleus, and everything else is abnormal. So this patient would get a score of 3 out of 10. Ideally, in all the trials that were done recently, they all favored patients with an aspect score of 6 or higher, which represent patients with less than 1/3 of their MCA territory involvement. So this is just another picture showing the aspect score. So this is the patient with a score of aspect score of 2. Compare that to the one with a normal score of 10. Talking about CT perfusion, and anytime we talk about CT perfusion, we talk about the mismatch. So we have 2 types of mismatch. We have the clinical core mismatch, and we have the perfusion imaging mismatch. A clinical core mismatch when we have a patient with, let's say, a high NIH stroke scale, let's say 15 or so, and then on their imaging, let's say you do a non-contrast head CT and their aspect score is like 9 or 10. So that tells you, based on your clinical exam and the aspect score, that this patient has a large area of mismatch. So you are basically the perfusion study for that patient. We can also quantify that by doing a perfusion exam, CT perfusion or MR perfusion, where you can actually see the size of the core infarct and compare that to the area or the tissue at risk, and the difference between the two will be your mismatch, and based on that you can decide if you need to treat the patient or not. Now, the way we do the CT perfusion is we inject the patient with small dose of contrast. It's usually 40 cc's of contrast that's given through a large bore IV in the antecubital area, and we start scanning the patient immediately for about 45 seconds. So the initial images will have no contrast, and then we'll see contrast coming through, and then the contrast will peak, and then after that the contrast will wash out and completely go away. So we'll get a diagram similar to this, where you have a peak and then the contrast goes away. And that's one of the things you need to look at when you look at CT perfusion, to make sure that the study is being done correctly. If you don't see the peak and the contrast washing out, that means that the exam is not reliable, and the images, you just cannot make a decision based on that. That exam is not good, so it has to be related. It has to be repeated. So we send this data to the computer that will generate excuse me, I'm having a problem with my laptop. In just a second, let me just fix this. I'm sorry, I'm having a problem with my computer. I may have to reboot.
Well,
Okay. Can you all see me? Okay, so we send the data to the computer, and we'll generate these colorful images where we basically, one of the images will calculate the cerebral blood flow, and the second one will calculate the cerebral blood volume, and the third and fourth will be like time images, and those will measure like mean transit time or time to peak. So basically, the perfusion images are not true images. They're more of a mathematical calculation. And unfortunately, every manufacturer has its own algorithm and way of calculating these images. So that's why those images will look different depending on the manufacturer that you have. So it's good to get used to what you have, or know what you have, and get used to that. Now, when I look at CT perfusion, I usually try to use the traffic analogy to explain how I interpret them. So think about it like if you're traveling on a road and there's a traffic jam because of an accident or whatever, and the traffic is backed up. So the flow of cars through that road because of the traffic jam will go down, so will decrease. So the flow will go down. And the same thing in the brain. When you have a blood clot, the flow of blood through that area will go down. Okay. Now your travel time through that road, again, there's a traffic jam. It's taking you longer time to go through there. So your travel time will go up. The same thing for the blood. It's going to take the blood longer time to go through that area because of the blockage. So the mean transit time or time to peak will go up. Now, these two usually will be matched. And when you have a patient with decreased cerebral blood flow and increased mean transit time, that tells you that patient has an ischemia. Now, the key image is going to be the cerebral blood volume image, because that image will show you if that patient has collateral flow or not, if that part of the brain is salvageable or not. So basically, if the blood volume image is symmetric or increased, that means that patient has an ischemic penumbra. If it's decreased, that means that patient has poor collateral flow and have a large core or has a core infarct. So here's an example of the normal scan. So we have the cerebral blood flow, cerebral blood volume, and then we have time to peak images. And you can see they're all symmetric. Now, right next to the image, you have that colored bar. It's important to look at that and to know what's high and what's low. And you can see, like on the ones I have, the red is high and blue or purple is low. Okay. And as you can see, the gray matter usually will have higher blood flow or higher colors compared to the white matter. Now here's an example of a patient who, you look at the non-contrast CT, looks pretty much normal. I would give this patient an aspect score of probably 10. Of course, I don't have the slice through that basal ganglia region. But if you look at the blood flow image on the right side, you can see there's a large area of decreased cerebral blood flow, almost involving the entire MCA territory on the right side. If you look at the transit time, the one below it, there's a large area of increased mean transit time, which matches the one. And usually those two images will be identical in terms of the area involved. They will match each other. Now, the cerebral blood volume image is the key image. And you can see on the blood volume images, the volume is decreased and almost matches the flow and the time images. So this patient has a large core infarct. So this patient will not be a good candidate for treatment. And here's another example where you see a patient on, again, similar to the previous one, right MCA occlusion, large area of decreased blood flow, increased time with decreased volume. So not much of a mismatch, so not a significant penumbra. Now here's another patient where on the blood flow images, you see a small area of decreased blood flow in the left frontal or temporal lobe. And this is matched by decreased volume. And on the CT, you can see a hypodensity in the same area. On the diffusion weighted images, instead of being bright, it's actually dark. So that patient had an old infarct in that area. So now we have this patient. Non-contrast head CT looks okay. The blood volume images show decreased volume in the left MCA territory posteriorly. This is matched by an increased transit time in the same area. The blood volume images are symmetric, they're normal, so this patient is a good candidate, has an ischemic penumbra. Here's another example, more profound, where you can see this is the patient with left MCA occlusion. There's decreased flow seen throughout the entire left MCA territory. This is matched by an area of increased time to peak in the same area. And then the blood volume images are symmetric, maybe a little bit more increased volume, which tells you there is increased collateral flow into that area, so that area is self-salvageable. This patient has a large area of mismatch. This patient has a large area of ischemic penumbra that we can go after. Now, instead of having to look at those images individually and try to decide, okay, is there a mismatch and how big of a mismatch there is, there are actually softwares now that can calculate that automatically. And this is one of them. This is called the RAPID software. And this is the one that was used in most of the trials that will actually calculate the mismatch for you and tell you if the patient has a mismatch and quantify that for you, which is really nice. Now, it is nice that we are able to do all these advanced imaging techniques for those patients, but is it really worth it? I mean, that comes at a cost, okay? These images, it takes time to do these images. And are we really helping those patients or harming them? Besides, there's really no standard way of looking at these images, like CT perfusions. Every place has its own way of looking at these images. Every machine calculates the penumbra in a different way. And also, there are many technical failures. I mean, I can't tell you how many times the IV blows up, or they can't get an IV in the AC, and so forth, and that just causes further delay of these patients. Now, what about MRI? The MRI is considered the gold standard, and of course, diffusion-weighted imaging is the one that we look for. That's what's called the stroke sequence. Anything that's right there is considered dead tissue, core infarct. It's non-salvageable. We can do DWI, we can do MR perfusion, we can do MRA. MRI helps us determine stroke acuity. It's also helpful in posterior circulation infarcts, patients with lacunar infarcts, embolic strokes, and also helps us differentiate the stroke mimics and make sure that they are not true strokes. So when do you consider doing an MRI? So when the patient has stroke symptoms, but the CT is negative, or patients who are patients with wake-up strokes, unknown time of onset of their symptoms, young patients, and also when we are suspecting like stroke mimics. I'm not going to go through these cases because many of you, I mean, you've all have seen these MR cases. This is just a repeat of what we talked about. Now, these are the stroke mimics. So this is a patient presented with symptoms that mimic stroke, that mimics right MCA occlusion. So this is the MRI DWI, which shows restricted diffusion in the right temporal lobe. This was thought to be a stroke, but turned out to be more of a herpes encephalitis. This is another patient that had an area of restricted diffusion in the right medial temporal lobe that turned out to be a status epilepticus. This is a patient with restricted diffusion in the left basal ganglia region, left temporal lobe, ended up having a low-grade glioma. Okay, so this patient, it's nice that we are able to do all these advanced imaging techniques, and this paper shows that the patients who were selected based on these advanced imaging techniques actually had better outcomes. This is the algorithm that's being followed. This is the Mass General protocol where they use MRI pretty much for all their stroke patients. They actually have an MRI in the ER where they image every stroke patient. And this is a paper that they published 2 years ago showing that their percentage of favorable outcomes is 74%, which sounds really great, but I will come back to this number in a little bit. Now, again, it's nice that we are able to do all these advanced imaging techniques, but this comes at a cost. This is a paper from the University of Miami that looked at patients who had only CT and patients who had CT plus CT perfusion and additional images. And they showed that there was a delay of about 28 minutes when we do these advanced imaging techniques. Now, this is another paper from Emory that showed that they looked at their patients that had only CT, and they looked at their time from image to puncture. So when patients only had a CT, the time from the CT scan to the groin puncture was about 61 minutes. And now when they did CT perfusion, that time went up to 114 minutes, so it's almost doubled in time. And if they did an MRI, that added another 10 minutes to that, so 124 minutes. So almost the patient delay was doubled when we added those advanced imaging techniques. Now, is that really important? I mean, delaying the patient for about 15 minutes, 30 minutes, or 1 hour, is that really important? It turned out to be, yes, it turned out to be very important. I mean, this paper showed that for every 15 minutes faster we reperfuse after hospital arrival, we are able to save 4 patients out of 100 from major disability. And we are able to improve the functional outcome in about 2.5 patients. That's for every 15 minutes. So if you delay the patient because of all these additional scans that we want to do, we delay the patient for 30 minutes. So that's 8 extra patients that will have more disability, and 4 patients will have less functional outcome because of that. And you can see how that multiply, with time. Now, let's look at an example. So you have a 62-year-old male patient with a sudden onset of left arm and leg weakness, NI stroke scale of 15. His symptoms started about 110 minutes prior to arrival to the ED. So we do a non-contrast head CT that showed an aspect score of 9. CTA showed a right M1 occlusion. TPA was given to the patient. So this patient has a right M1 occlusion, so that's a large vessel occlusion. So we know TPA, so we know that this patient eventually will have to go for mechanical thrombectomy. So the question is, do you need more information than what you have right now? Do you really need to scan to do a CT perfusion or do an MRI? Okay. Will you get more information with these studies? Of course, you are going to get more information with these studies. You'll be able to visualize if there is a core infarct, the size of the core infarct, and the mismatch and everything. But do you think that information will really change the way you will manage this patient? Do you think that information will prevent you from taking the patient to do mechanical thrombectomy? I mean, think about it. You have just given this patient 90 milligrams of systemic TPA based on non-contrast head CT alone. And now you want to stop and delay the mechanical thrombectomy for at least another 30 minutes, if not another hour, just because you want to know or you want to have more information. That's really not going to change the way you will manage that patient in any way. So is it really worth it? Now, if we look at like the screening process, so we have the rigorous screening process and we have a more simplified screening process. So with a rigorous screening process, when we are more strict, we are treating less number of patients. Our workflow is much slower because it's taking us longer time to move these patients through these advanced imaging techniques. And while we are delaying this patient, remember, this ischemic penumbra thing is a dynamic process. So when we do a CT perfusion and we see that the patient has an ischemic, the patient has an ischemic penumbra, that ischemic penumbra is what the patient has at the time you image that patient, because neurons die every minute, like we saw earlier. So if you do the CT perfusion now and then you do the mechanical thrombectomy an hour later, that ischemic penumbra is completely different. And more neurons have died ever since you scanned that patient. Now, the other thing we have to worry about when we have a more rigorous screening process is what we call the denominator fallacy. And I will talk about this in a little bit, but basically what it means is because we are more strict, we are treating less patients. What happens to the other patients that we are not treating? Nobody's talking about those patients. Like with the Mass General report, when they talk about their success rate of 74%, what happened to the other patients that they did not treat that may have benefited from treatment? Okay, we don't know about that. Now, with a more simplified screening process, we are able to treat more patients. Our workflow is much faster. We are able to triage these patients faster. And the only thing we have to worry about is ceiling effect, which means we are treating more patients than we're supposed to. Now, let's talk about the denominator fallacy. So let's say we have 100 patients with acute ischemic stroke, okay? And we follow the more rigorous or strict screening process. So we do an MRI on all these patients. And because we are doing the MRI, we are able to detect 4 patients who have a favorable scan and would qualify for mechanical thrombectomy. So we do a mechanical thrombectomy, and we have 30 patients with good outcome. So our success rate is 75%, or good outcome is 75% based on that. Now, let's say if we follow the more simplified screening process, okay, and we do a CT for those patients, a non-contrast CT. Okay, out of the 100, we are able to identify 70 patients who have favorable scan, because CT is not as sensitive as MRI. So we will able to find more patients. Okay, so if we treat 70 patients, and let's say the percentage of good outcome was 50%, so we were able to have 35 patients with favorable outcome. Now, even though our percentage is lower compared to more strict criteria, so it's only 50% compared to 75%, but we were able to actually help more patients using the simplified screening criteria compared to the more strict and rigorous criteria using an MRI, for example, or CT perfusion or whatever. So when somebody comes to you and say, well, the percentage of our good outcomes is like 70 or 80%. I mean, you have to ask them, okay, what about how many patients you are treating? Okay, what about the patients you are not treating? Are you really helping patients in your community by excluding so many patients from treatment? And this is a good question, because this is a survey that actually asked people in the community about their opinion. What do they favor? Do they favor maximizing the absolute number of patients who may benefit from the procedure, or maximize the proportion of treated patients who benefited? And as you can see, I mean, most clinicians would favor the latter, which is try to identify the patients who will definitely benefit from treatment. And most people in the community will actually favor treating more patients, hoping that we will be able to benefit more patients in the community. So this is from the University of Pittsburgh, which is one of the busiest stroke centers in the country, where they have a large number of their patients come via transfer. So what they did, they looked at all their transfer patients, they took straight to the angio suite, and the patients who came through the ER actually had to go through the process of advanced imaging doing CTA, CT perfusion. And you can see that the patients who came through the ED, their door to angio suite was 67 minutes compared to the ones that came through a transfer, where the door to angio suite was 10 minutes. And then when you look at door to puncture was 80 minutes for the patients who came through the ER, compared to 22 minutes for the patients who were transferred. And door to recanalization, again, was almost half of that time. And the reason for that is because the patients who were transferred did not have to go through that advanced imaging process, did not have to have CTA, CT perfusion, and the ones that came through the ER had all these advanced imaging techniques before they went for treatment. This is an 84-year-old female patient with history of COPD, atrial fibrillation, and diabetes, was admitted with shortness of breath in the setting of a non-STEMI MI. Prior to a planned TEE, the patient developed sudden onset of right-sided weakness and global aphasia. Her NIH stroke scale was 28. She was not a candidate for IBTPA due to elevated PTT. Now, the time of onset of her symptoms was 9:20 a.m. CT head was done at 9:30 a.m. She arrived at the angio suite at 9:40 a.m. Groin puncture was at 10, and recanalization or TQ3 recanalization was at 10:18 a.m. So in less than 60 minutes, the patient was completely opened up. And here's the non-contrast head CT. Here's the arteriogram showing the carotid terminus occlusion. Mechanical thrombectomy was performed, and the artery fully opened up. And here's the MRI, DWI, showing no ischemia, no stroke. So this patient only had a non-contrast head CT. We know exactly the time of onset of the symptoms. And is there really any reason for us to delay the care of this patient and stop and do CTA, CT perfusion, or even MRI? Would that really make any difference in the way we were going to manage this patient? If the patient did not have the contraindication to the TPA, then this patient would get the TPA right away and then go to the angio suite. But because they had the contraindication, they went straight to the angio suite. So the main advantage of doing these advanced imaging techniques is to help us identify the core infarct and what's the size of the core infarct. But is that really important for us? And we always worry about patients having a large core infarct. Now, what is the percentage of patients who present within the first 3 hours or 6 hours from the time onset of their symptoms who have a large core infarct? This is actually from the Hermes Meta-analysis, and they looked at the patients with different aspect scores, and they found that the patients with an aspect score of 0 to 5, which is patients with large core infarct, within the first 6 hours from the time of onset of their symptoms, and those patients were only 16% of the overall patient population. So only 16% will present within the first 6 hours with a large core infarct. So are we willing to harm the remaining 85% of patients just so we can identify those 16% of patients? What about in the first 3 hours? That percentage goes even further now. There's only 4% of patients who present with a large core infarct within the first 3 hours. So again, if you have a patient who comes with acute ischemic stroke symptoms within 3 hours from the time of onset of their symptoms, so are you willing to harm 96% of patients in order to identify the 4% of patients who present with a large core infarct? Is it really worth it? Okay. So this is a slide from the DAWN trial where they looked at patients with large core infarct. Of course, those patients were, they got into the trial by accident. Those are the patients who were initially looked at by the interventionalist, the neurointerventionalist, and they looked at their aspect score and they gave them a score of 6 or so, and then treated the patient. And then later on, when the images went for review at the core lab, they changed the aspect score from 6 to 4. But by then, the patient was already enrolled and treated. So if you look at the percentage of patients, and those are the patients that are labeled ND, which means they're non-DON, non-diffuse. The percentage of patients who had a modified Rankin score of 0 to 2 was 30%. Of course, it's not as good as the 54% for the patients in the DAWN trial, but it's definitely better than the 12% in the medical treatment arm. Here's another paper from the Hermes Meta-analysis that shows that patients with an aspect score of 3 to 5, those are patients with a large core infarct, the odds ratio are still in favor of treatment. Now, this is again from the Hermes Meta-analysis when they looked at the patients trying to decide which patients had a mismatch and which one did not have a mismatch, because that's one of the things we look at when we do a CT perfusion or MR perfusion. Does the patient have a large area of mismatch or not? They found that 95% of patients had a mismatch by the Swift prime criteria, and 78% of patients had a large penumbral volumes. So 78% already have a large area of mismatch without even having to do CT perfusion or MR perfusion. Now, what about NIH stroke scale? Can we use that to identify those patients who have large vessel occlusion and can benefit from treatment without having to do any advanced imaging? So this paper showed that the best NIH stroke scale cutoff to show a large vessel occlusion within the first 3 hours was 9, and with a positive predictive value of 80.7. And within the 3 to 6 hours, the NIH stroke scale was 7 with a positive predictive value of 77. So if you have a patient with NIH stroke scale of 10 or higher, you are almost certain that that patient has a large vessel occlusion and has a good size area of mismatch without significant core infarct and would qualify for treatment. What about patients with low NIH stroke scale? Again, this paper shows that those patients with low NIH stroke scale, the odds ratio still favor treatment. Okay, and that's important because we know that there is a bias, like NIH stroke scale is geared more toward left MCA or the dominant hemisphere compared to the non-dominant hemisphere. Just because the speech is not involved, patients with right MCA occlusion lose 5 points. And because of that, their NIH stroke scale may seem lower compared to a patient with left MCA stroke, but yet those patients can also benefit from treatment. And we have to keep that in mind. So in order to exclude 15% of patients who may not benefit and are very unlikely to be harmed, we harm the rest of 85% with doing all these advanced imaging techniques that will take time to do, like we saw. Now, I showed you that slide earlier, like the goals of doing these advanced imaging techniques is to rule out hemorrhage, rule out absence of occlusion, rule out large core infarct, rule out absence of a small at-risk tissue. But basically, we are doing these images or these advanced images to exclude more patients from treatment. Now, we all know that time equals brain, but also imaging equals time because we are wasting time when we do these imaging techniques. So therefore, imaging equals brain. So the more studies we order, the more we have to put the patient through, the more brain cells we are killing. So we have to keep that in mind. So within the first 6 hours, okay, chances are good that that patient has a good size ischemic penumbra, a good size mismatch, a small core infarct. So those patients those patients will benefit from moving them really fast because the fast progressors that we talked about earlier in my talk don't have much time. So we can't waste any time with them. We have to take them right away and try to open up the vessels to limit the size of the core infarct. Now, patients who present beyond the 6-hour window, by definition, those are the patients who are slow progressors, okay? So those patients have good collateral flow. Those patients have the time. If you're not sure and you want to do more imaging, that's fine. Those are the patients you can study. You can do CTA, CT perfusion, study them because they have good collateral flow. They can tolerate that. But within the first 6 hours, and definitely within the first 3 hours, we need to move faster. We don't really need to waste time doing CTA, CT perfusion, MRI, unless we absolutely have to. Okay. If you look at the imaging criteria, selection criteria that was used by the different trials, you can see that Dawn and Diffuse had the more strict criteria, and that's, of course, because they were looking at patients beyond the 6-hour window. But again, those are the patients who are the slow progressors. Those are the patients that have collateral flow. So you can do that. But then when you look at the other trials that looked at the patients within the 6-hour window, they pretty much relied on the aspect score. So CT perfusion, yes, they did it sometimes, but it wasn't like the main selection criteria. So this is from the TREVO registry that came out last year, and this was started several years ago. This is more of a real world data, and you can see in patients who were selected based on CT alone compared to patients who were selected on CT plus advanced imaging techniques. You can see the outcomes are comparable between the two, and actually there's a shift to the right side with the CT only, which means there's a trend toward better outcome in that patient group. So we need to change the way we approach those patients and think about studying them. So we need to, especially patients who present within the early time window, we should try not to waste time unless we absolutely have to. If we think that I absolutely have to have this study because it will answer this question for me, which is important. Otherwise, there's no reason to waste time with these advanced imaging techniques. Now, if a patient presents later on after the 6-hour window, that's fine. You can do CTA, CT perfusion, MRI, because those are the slow progressors. They can tolerate that. And thank you.
Thank you, Dr. AbuAwad. I apologize for the interruption, but if you guys have any questions for the doctor, go ahead and enter them in the Q&A on the left-hand side of your screen. He'll be happy to answer any questions that you might have. Any advantage for MRA over CTA head and neck?
No. Actually, MRA sometimes can overestimate, like if we're looking, especially in the neck, if you're looking for a stenosis, MRA sometimes can overestimate the degree of stenosis. The only time I would do an MRA of the neck is, this is a new thing, if we are imaging the plaque in the carotid bulb region to see if it's something that's like a soft plaque and so forth, or if it's a hard plaque, a chronic plaque. But CTA it's much quicker to do, and it's readily available, and it's more reliable and it's easier to look at. The only advantage is with CTA you have to give contrast, which can affect the kidney function. The MRI or MRA, most of the time you can do it with just time of flight, which is without contrast. So in a patient with renal function issues, I would definitely consider MRA over CTA.
Great. Thank you very much. Any other? All right. I am an EM physician. If we streamline protocol for stroke alert where get CT non-con, CTA head and neck, will this eliminate need for MRA on the back end?
Yes, absolutely. Yeah, there's no need. If you already had a CTA, there's no need to do MRA after that.
Great. Thank you very much.
Thank you.
Oh, hey. The only thing we would need is MRI brain after that, correct?
Correct.
I apologize that you can't see these. He said thank you. Also, I will be sending out my contact information. If you have any other questions for Dr. AbuAwad, I can certainly pass them on to him. He's been a wonderful presenter today, and thank you very much for presenting in our first webinar. And you guys have a great afternoon.
Thank you. Thanks again for inviting me.